All right, so as promised, I am going to finish talking about the drugs for neoplasms. I figure I might as well just start off at the first drug category. So that is going to be the alkylating agents. So give me 1 second to switch to that. All right, here we go. So if you remember, I talked a little bit about alkylating agents. They are the oldest classification of anti-neoplastics, been around since the 40s. They are the most widely used. They are non-cell cycle specific, so what that means is they can affect cells even in the resting phase. The cancer cells are killed by altering the shape of the DNA double helix and by preventing the DNA from duplicating during cell division. They do have a broad spectrum, meaning that they're used for different types of malignancies or cancers. They are the most useful at treating slow-growing cancers, so those would be things like your lymphomas, leukemia, and myelomas. There are two types. There are nitrogen mustards and nitrosoureas. More on alkylating agents. They are category D, but as I mentioned in class, all chemo is contraindicated during pregnancy. It can be given either PO or IV. The adverse effects, some GI toxic effects, so things like anorexia, nausea, vomiting, weight loss, diarrhea, and mouth sores are pretty common. And I want you guys, as you start learning the different adverse effects, think about what nursing can do to help this. So what kind of things can we do for anorexia? Nausea, vomiting, for example, we could treat them before they get the chemo with an antiemetic, right? Weight loss, diarrhea, mouth sores, those kind of things. So this is what I want you guys to think about when you're looking at the adverse effects. They also cause some toxic skin effects. Alopecia is pretty common, along with acne, blistered skin, darkened or thickened skin. Alopecia is actually pretty frequent with this drug, especially compared to other drugs. It causes the most alopecia. About 50% of patients will develop total baldness when receiving this chemo. The next thing up are the heme effects, so things like bone marrow suppression. Bone marrow suppression is the primary dose-limiting toxicity, and what this means is this is usually what brings them to withhold the chemo for whatever reason. So I believe I gave you an example of my fiance's mother who is undergoing chemo for cervical cancer. She has not been able to have her last 3 chemo cycles because her white blood cells and her red blood cells are too low. So that would be dose limiting. The bone marrow suppression can be potentially life-threatening, so it is really important that people are having their levels drawn periodically through treatment. Usually they check them before each cycle. Unfortunately, it also comes with the risk of secondary cancers. A small number of people do develop myelogenous leukemia 4 or more years after chemo is complete. You could also develop cardiotoxicity, hepatotoxicity, renal toxicity, jaundice, and pulmonary fibrosis. Potentially irreversible infertility. They are a strong vesicant, so people receiving alkylating agents, it needs to be through a very large vein or more preferably a port. And cancer cells can develop resistance with prolonged treatment, so because of that, it's usually given with a mix of something else. Drug-food interactions, they increase anticoagulant effects. They also interact with agents that cause bone marrow suppression, cardiotoxicity, hepatotoxicity, and renal toxicity. They increase the risk of all these things. And then good old St. John's wort can increase the toxic effects of cyclophosphamide. And cyclophosphamide is your prototype for the alkylating agents. Just to remind you, the nursing considerations are not an exhaustive list, just something to help you to start thinking about what monitoring and education needs to be provided by you as the nurse. And that would be to pre-medicate with an antiemetic to hopefully prevent some of that nausea. Nausea is much easier to prevent than it is to treat once it does occur. Definitely need to monitor weights and INOs, labs such as CBCs and electrolytes, monitoring for any signs or symptoms of infection, and teaching them ways to avoid infection. They cannot take a live virus vaccine because they are going to be immunosuppressed. They're at risk of developing whatever that virus is. And then there are 2 chemoprotective drugs for alkylating agents, the first being Mesna. It is a chemoprotective drug that can prevent hemorrhagic cystitis, and that's one of the risks with cyclophosphamide, your prototype, so they'll give this drug beforehand. Or there's also a chemoprotective drug that helps prevent renal toxicity when administering cisplatin, and cisplatin is another one of the alkylating agents. Next up, we have our antimetabolites. Just to remind you, antimetabolites are drugs that are similar to the nutrients needed by the cancer cells. So then the cancer cells try to use them, and we trick them because the antimetabolites actually disrupt the metabolic pathways. And this is going to result in the cancer cells slowing or dying. All right, so they're S phase specific. So what that means is they're most effective against rapidly dividing cells. There are 2 types. There's folic acid analogs, and then your purine and pyrimidine analogs. Some examples of cancers treated by antimetabolites, your leukemias, lymphomas, and some GI cancers. Use is limited for these because the cancer cells do rapidly develop resistance, so they're usually, again, part of a combination therapy. They wouldn't be given alone. They do have a broad spectrum use, but again, work better against rapidly dividing cells. They are used in both children and adults. And just to remind you, they're also used for rheumatoid arthritis and other autoimmune diseases. They are part of the DMARDs, and then they're also used to terminate pregnancy. So mechanism of action, again, they inhibit DNA production in cells that depend on certain natural metabolites. They are a category X, and they can be given in all sorts of routes: PO, IM, IV, sub-Q, and intrathecal. Adverse effects, the GI effects, nausea and vomiting is very common, anorexia, ulcerative stomatitis, so those are the mouth sores, and diarrhea. The last 2, the ulcerative stomatitis and diarrhea, actually can sometimes require treatment to be stopped because it can lead to hemorrhagic enteritis and death from intestinal perforation. So you definitely want to keep an eye on your patient and how much diarrhea they're experiencing. Comes also with hematological effects, so bone marrow suppression, leukopenia, thrombocytopenia, and anemia. Some CNS effects: headache, drowsiness, aphasia, fatigue, malaise, and dizziness. Nephrotoxicity, pulmonary toxicity, and renal toxicity are also a risk. Lead to potentially fatal opportunistic infections, and they come with a black box warning because combining them with an NSAID can cause severe and sometimes fatal myelosuppression. All right, don't take it if you're pregnant, lactating, if you have thrombocytopenia, anemia, any of the emias, because it's going to increase the risk of that, or if you are an alcoholic, and that is because of that risk of hepatotoxicity being so much more intensified. Interacts with other agents that cause bone marrow suppression or hepatotoxicity. Food delays absorption, so they should definitely take this on an empty stomach. And the prototype I have for you is methotrexate. And methotrexate blocks the enzyme responsible for converting folic acid to folate. Nursing considerations for antimetabolites would be to monitor CBC before treatment and weekly, monitoring and educating on infection, monitoring for thrombocytopenia, so looking for bleeding, bruising, petechiae. You want to monitor for oral and gastric ulcerations, monitor your liver function and respiratory status, and then there is a rescue drug called leucovorin for methotrexate, and what this drug does is it's a reduced form of folic acid, so this reduced form can enter into regular healthy cells, but it can't actually get into the cancer cells. So that way the rest of the body doesn't experience as much folic acid depletion. It's also the drug for methotrexate overdose. If I remember correctly, this is the slide we left off on in class. It is the anti-neoplastic antibiotics. They aren't used to treat bacterial infections. I know they say antibiotics, but they're only used for certain cancers, and the reason behind this, as you'll see in the next slides, is because they're so toxic. So the way they work is they bind to DNA and affect its function, and they are more toxic to cells that are multiplying rapidly. Their mechanism of action is actually really similar to alkylating agents. So when you look at the actions and adverse effects, you'll also notice that they are very similar. All right, so again, the mechanism of action is that it binds to DNA, causing inhibition of DNA synthesis. They do have a wide spectrum of anti-tumor activity. It's actually considered one of the most effective agents against solid tumors, is this drug class. They are a category D, and they're given IV. Some adverse effects would be toxic GI effects, so severe nausea, vomiting, anorexia, diarrhea, mucositis, rash, excessive lacrimation, which would be excessive tearing. Toxic bone marrow effects can cause bone marrow suppression, thrombocytopenia, and anemia. Also comes with the risk of hepatotoxicity, renal toxicity, anaphylaxis, complete alopecia, and severe local necrosis. It does cause a temporary decreased fertility. It's not permanent though. Risk of secondary malignancies, and it also carries a black box warning. That black box warning is because of the risk of severe myelosuppression, cardiotoxicity, and anaphylaxis. Don't take it if you're pregnant, lactating, already myelosuppressed, or have cardiac disease. And they interact with other cardiotoxic or immunosuppressive drugs. The prototype for you guys is doxorubicin. And interestingly enough, it does cause your tears and your urine, so all of your body fluids, it causes it to turn this reddish color. It is harmless, but as I've said with some of the other drugs that do this, you need to give the patient warning, because could you imagine sitting there watching a sad movie and then you start crying red? So make sure they know that this could happen and it is harmless. All right. As the nurse, you're going to want to monitor labs such as CBC and LFTs. You want to, again, educate them on the red tears in urine, and then monitor for cardiac toxicity. So anybody taking this drug needs to have a baseline function, usually with an ECG and an echocardiogram, and then they need to have follow-up monitoring. The vital signs and heart rhythm need to be checked, and there is a cardioprotective agent called dexrazoxane that they can take to hopefully limit some of the adverse cardiac effects that come along with doxorubicin. Another drug class for your anti-neoplastics is hormones and hormone modulators. They act by blocking the substances essential for tumor growth. They're actually not cytotoxic, meaning that they don't cause all the life-threatening toxic effects of all these other drugs we've already talked about. They can cause serious adverse effects in high lung doses for prolonged periods, but they are actually safer than the typical anti-neoplastics we've talked about. Their use is limited to hormone-sensitive cancers of the breast, prostate, ovaries, uterus, and testes. As I said, they're not cytotoxic. They block or interfere with hormone receptor sites of the tumor. They are normally given for palliation. Unfortunately, they rarely produce cancer cure when used alone. They're broken down into 4 general classes. There are your SERMs, which, if you remember, we talked about when we talked about osteoporosis and when we talked about hormone replacement therapy. And then there's your aromatase inhibitors and your gonadotropin releasing hormone analogs. And finally, the 4th one is androgen receptor blockers. So your SERMs are used for breast cancers where estrogen receptors are overexpressed. So it's for your estrogen positive tumors. It is not for all types of breast cancer. Estrogen actually in an estrogen positive tumor is going to promote the growth of that tumor. So the SERMs have anti-estrogen effect in breast tissue, so they slow the tumor growth. And if you remember all of the adverse effects we talked about when giving SERMs, this will apply to people taking these as well. So your aromatase inhibitors, aromatase is an enzyme that catalyzes the last step in estrogen synthesis. So by blocking this step, it's going to reduce the amount of estrogen in the blood, which will starve the estrogen receptor positive tumor of a major growth stimulus. Okay. So basically what that means is it is going to keep the tumor from growing if it is an estrogen positive tumor. They're only effective in postmenopausal women, and the reason is because it can't block estrogen production in the ovaries. And it's the primary site of production in premenopausal women. So this only works for women who have gone through menopause, whether it was surgical or natural, anyone without ovaries. All right. The 3rd one is gonadotropin releasing hormone analogs, or your GnRH analogs. And these are approved for the management of prostate cancer. And they work because they cause a loss of testosterone to almost zero, so it's actually considered a type of chemical castration. And the loss of testosterone starves the cancer cells of the hormone essential for its growth. So this is going to cause sterility, so your patient would need to be aware of that. And then the final one, the androgen receptor blockers, prevent testosterone and other androgens from reaching the receptor in the cancer cell, so again, used for prostate cancer. You will see SERMs used a lot more frequently, so because of that, I focus on them. They, again, are for ER or estrogen receptor positive tumors in men and postmenopausal women. Prophylaxis of breast cancer. It is actually the only anti-neoplastic approved for prophylaxis for women who have a high risk of developing this type of breast cancer. Or they use it as adjunct therapy following a mastectomy. They work by binding to estrogen receptors, producing antagonist effects in breast tissue, so the tumor growth is slowed. It is a category D, given orally. Adverse effects, again, when you think estrogen, your big one is going to be the thromboembolic disorder. So risk of pulmonary embolism, DVT, and stroke. But then it also causes nausea, vomiting, hot flashes, vaginal discharge, irregular periods, vaginal bleeding, fluid retention, headache, lightheadedness, and rash. And they come with a black box warning because they have an increased risk of endometrial cancer. This would, of course, be the most serious adverse effect, followed by thromboembolic disorders. Do not take them if you're on anticoagulant therapy or a history of thrombotic disease, pregnancy, lactation, or if you already have pre-existing endometrial hyperplasia, because your risk of endometrial cancer is going to be much higher. They interact with warfarin. They increase the risk of bleeding. SSRIs, by decreasing the effectiveness, so the SSRIs decrease effectiveness of the SERM. And then if you take a SERM with oral contraceptives, it intensifies your risk of thromboembolic disease. Your prototype for your SERM is tamoxifen. Nursing considerations for SERMs are to monitor for GI effects, hot flashes, and visual disturbances. And then looking for signs and symptoms of thrombus or stroke, so things like leg pain, shortness of breath, or weakness. The next class is your mitotic inhibitors. They are all derived from plants. They all have the common ability to arrest cells as the process of mitosis begins. There are 3 subdivisions. The vinca alkaloids were actually derived from the periwinkle plant. I'm not going to test you on what plant they came from, but I find it interesting. Then the taxanes were derived from the bark of a Pacific yew, which is an evergreen tree. And then topoisomerase inhibitors were first derived from May apple plants. And topoisomerase is needed for DNA to perform its normal functions. So it inhibits this enzyme. So more on mitotic inhibitors, and another way they are called is natural products. So they are used for a broad spectrum of cancers, and they work by inhibiting cell division. Category D, and these are only given IV. Adverse effects, your mitotic inhibitors are actually very toxic. So your heme effects, bone marrow suppression, leukopenia, anemia, and thrombocytopenia. CNS effects, neurotoxicity. So it can cause things like paresthesias, peripheral neuropathy, motor difficulties, and cranial nerve palsies. And this may actually take several months to resolve after treatment ends. I know this is one of the chemos my ex was on, and he did develop peripheral neuropathy. He said it felt like his feet were always, that tingly feeling when they fall asleep and then you stand up on them? That's what they always felt like. And of course, with this comes a lot of risk for safety fall issues. So you're going to want to be careful with that. And unfortunately, it does take a long time for it to resolve. Some other CNS effects would be seizure, depression, hallucinations, and coma. GI effects are nausea, vomiting, anorexia, stomatitis, severe constipation, abdominal pain, and paralytic ileus. Kids in particular are very at risk for paralytic ileus, which is an intestinal obstruction that's caused by the paralysis of the intestine. Some other toxicities or adverse effects would be hepatotoxicity, skin rash, and alopecia. Extravasation, which is just a really fancy word for the vein to leak and cause like tissue necrosis and stuff around that. So again, definitely wanting to give this medication through a port versus just like your regular IV. And they come with a black box warning because of severe myelosuppression and opportunistic infections. Anyone who's had radiation to the liver should not be on this. An active infection, or men and women of childbearing age, pregnancy, lactation, and infants. And the prototype is a vinca alkaloid, and it is vincristine. Nursing considerations would be to monitor for peripheral neuropathy, check deep tendon reflexes and muscle strength, and expect that the dose will be lowered if neuropathy does occur. You want to monitor for signs and symptoms of infiltration and monitor for any constipation. The final anti-neoplastic class we're going to talk about are the biologic response modifiers and targeted therapies. These are a substance that enhances the ability of the body's defenses to remove the cancer cells. And they do this by directly binding to the cancer cells and destroying them, or by activating general aspects of the immune response. There are two general classes. There's your cytokines and your monoclonal antibodies. Within the cytokines, it's broken down into your interferons, which are natural proteins produced by T cells in response to antigens. And what they do is bind to specific receptors on cancer cells and suppress cell division and enhance phagocytosis. And then there's your hematopoietic growth factor. And these enhance the ability of the immune system to respond to reduced myelosuppression. So your hematopoietic growth factors are actually not chemo. They're used to help with the adverse effects of chemo. So these include things like your apoetin alpha or filgrastim. And then finally, monoclonal antibodies, which is also considered target therapy. It is anti-neoplastic drugs that have been specifically engineered to attack cancer antigens of a specific cancer. This is actually where cancer research is centered lately. I know the U is doing a lot of research on targeted therapy. And basically what they're hoping with that research is, eventually, let's say you go in because you have breast cancer. They will be able to look at your DNA and create a chemotherapy drug that is very specific to just you. Right? But what they have found currently is that different cancers do have different antigens. So, for example, a brain tumor has different antigens than a tumor in the breast. It's kind of neat. So, once a monoclonal antibody binds to a cancer antigen, it's either going to directly kill the cancer or marks it for destruction by the immune response. An example of this would be the monoclonal antibodies that target breast cancer with HER2. HER2 is a specific type of metastatic breast cancer. What it stands for is human epidermal growth factor receptor 2. And finally, I have a list of some drugs that are given to reduce the adverse effects of the chemos. This is in addition to all of the rescue drugs we talked about throughout. So things like antiemetics are given to nearly all patients undergoing cancer chemotherapy to decrease or prevent nausea and vomiting. It's time for me to take my antibiotics. Sorry about that. What else? So GI drugs are given to either reduce diarrhea or constipation, depending on what the person's experiencing. Then there's the drugs that are used to prevent complications of myelosuppression. So I mentioned about colony stimulating factor, your apoetin alpha. This can actually stimulate red blood cell production. Or if you give filgrastim, it enhances neutrophils. Or if you need to stimulate platelets, there is a drug for that as well. On top of that, analgesics for pain are given, antibiotics either for prophylaxis or treatment of infection, appetite stimulants, and antidepressants all might be prescribed for your person who is undergoing chemo. And that is all I have for you. Just email me if you have any questions on any of these specifically.